We also have the resilient system strengthening for health, that is community system strengthening largely, which relates to scorecard activities. And up to now, we're waiting for Global Fund to give us clearance. Once we get clearance on the consultant to do the scorecard, then we'll be good to go. The other activities relate to TB care and prevention, and largely is contact tracing, which we do across the country. In the region where the meeting has happened, it is Baylor as a subrecipient that takes the implementation. What have we been able to do for the period January to December? Were able to, and again, I have not zeroed down specifically to trickle down my presentation to only young people, because at the end of the day, this young person has an ecosystem around that needs to be facilitated. If we do not support them, then we are not supporting the young person. So we looked at the different categories as well, so that I bring out everything. And we know that when we go to MSMs, of course, we find there the young people. When we go to female sex workers, we find there the young people. Of course, the adolescent girls and young women specifically. So in that period, January to June, we weren't so well. We weren't so implementing so well because of there's other decisions that have to be made that are beyond TASO, especially relating to subrecipient selection, which is always a need from the communities, and they feel that TASO is letting them down. But I want to say it here that that is a decision that is solely made by the Global Fund. You do your process, you conclude it, you're fine, and the communities may be happy. But when the Global Fund says no, you repeat the process. And this ideally affects us so much. It affects the timeliness of start of implementation. It affects the autonomy of the principal recipient as an implementer. And at the end of the day, your hands are tied because you have to wait for decisions to be taken. And of course, sometimes you cannot blame the Global Fund for what is happening, because they say history is a best teacher. And we are learning from what happened in 2007, where most of you were not yet born, where funds for the Global Fund were abused. And as a result, we are pushed to corner so that things can be done, but it affects us. So these are indicators that we report to, or we report on to the Global Fund, and all the indicators are part of what is in the national M&E plans, and specifically for MSMs that have been reached with HIV prevention programs with a defined package. We had a target of 4,500, sorry, a target of 5,900, and we achieved 4,500 January to June. And the following semester, that was July, December, were able to reach 5,000. For those that tested and knew their status at that time, we had a target of 5,333, but we were only able to reach 4,722. And for those that were tested and in July, December, were 5,333. We managed to get 5,000. For female sex workers that have received a defined package for HIV prevention programs, we had a target of 22,000 and we got 18,000. So for these first four indicators, you will realize we were performing well in the very first semester because MAPI was not affected. It is a pre-selected SR. So once the grant transitions, they close out the first one and they sign in the second one. So these are not were not greatly affected. So we're able to achieve not less than 90%. For those that have received a defined package, we had 22,000. We achieved 21,000, which is good enough. For the sex workers that were tested and knew and got their results, we had 18,000 out of 20,000 that was targeted. And then the second semester, we got 21 out of 20 that was targeted. That was even above the target. For adolescent girls and young women, for the first semester, that is June, we had a target of 20,850. And we got only 1,773. And the question is why? Because the implementers were onboarded in May, and the season, the reporting semester was ending in June. So when you look at recruitment of staff and the rest, you realize that this only is what we could have done. But when you look at on the other side and you look at when implementers were onboarded already and they were already implementing, you realize that we got 28,000 instead of 20,000 that was targeted. For the girls that were tested and got their results, we had a target of 6,000. We only achieved 1,000. That is the same reason. But we see a steady progress when we get to the second semester. Now, when it got to 2022, now we were all set and implementers set, the ground was leveled, implementation kickstarted. So for the adolescent girls that were tested, and again, now I start with them because I feel this is where our interest is now. We had a target of 3,000 and got 2,000. For MSMs that tested and knew their results, we had a target of 3,200 and we got 4,735. This ideally brings out how the key populations have really increased the level of access to services, but also the intensification of approaches of outreaches where we are going to the hotspots so that we find them where they are. And that is the approach that we are using as well for the young people so that we are able to provide more services. For the number of sex workers that received their results after HIV test, the target was 13 and we achieved 13,700. For the number of girls reached with a defined package, we had a target of 10,400 and we achieved 11,500. For MSMs that received a defined package, we had a target of 3,500 and got 4,763. For the female sex workers that had received a defined package for HIV prevention, we had a target of 14 and we achieved 13.8. Now here we start reporting about TB contact tracing because in the whole of 2021, there was a lot of groundbreaking implementers not being on board, bringing in the National TB and Leprosy Program on board to support the sub-recipients. Remember, this is a countrywide implementation, so we need support from the district TB and leprosy supervisors. We need the regional leprosy and TB supervisors. So it took us almost the whole year, but we realized that when it got to 2022, in the first quarter, we were able to get 24,000 instead of the 23,000 that was planned. So why am I presenting up to March 2022? We do not present unvalidated data. It is only until the data is validated and we're sure that what the subrecipient provided can saw Omicron coming in when we saw the schools and the gatherings were all put down. This affected the uptake and we had to really come up with accelerated work plans for implementation with subrecipients beyond COVID so that we are able to achieve for the lost time. There was also inadequate capacity of stakeholders, especially the subrecipients, the institution work with, the vendors we work with, on the strict and stringent compliance issues for the Global Fund, which people complain about all the time, how it affects them in participating in processes. I know even the people in this meeting, but largely is to let you know that even at TASO, it affects us because we are the same institution but the procedures that we work with under Global Fund are different from the team that work in under PEPFAR, under USAID, and other donors. So you find that it is hard to work with an individual. You have to engage them frequently for them to build capacities, but also coming up with a capacity building program, especially for the community-based organization. Then, of course, the untimely contact tracing that I talked about, we really needed district TB and leprosy supervisors, also making sure that they support us in data quality assessments, as well as following up so that reports are submitted. And then the other challenge is about inaccessibility, where we are finding ourselves stretching so wide in implementing. And then at the end of the day, you have districts like Wuko where access is a problem, and yet the beneficiaries there need the services. I may give you an example of the girls as a target.
Is like
Chair, I would request that the person is muted. Thank you. So we happen to find when you go to the national data, the data by UNAIDS, the data by PEPFAR, it does not rank Boko as high risk. It does not rank it as a vulnerable district. But us that are implementing there, it is the worst nightmare, where you will sample out 50 girls and 40 of them have babies. What does this mean? It means they are engaged in active sex and unprotected sex, and the risk of exposure is high. So some of the criteria that I would like the young people to carry forward is looking at flexibilities beyond the data from PEPFAR. What other socioeconomic factors can we consider, and health factors can we consider to identify the most vulnerable districts? I realize some of the districts are really left out. If you look at districts like maybe in Toroko, especially the border districts and the lake districts, but we know the sexual activities going on and how the young people are affected. So what are our plans? Really, our plans here, we have started scaling up to other sub-counties. In NFM1, we worked in 3 because it was more of a pilot. 2021, we worked in 3. In this year, we have scaled up to the other 3. In some other districts, it's 4. We intend that next year we should also roll out to the other 3 sub-counties so that we are able to circulate at least 80% within a district to make sure that we comb out the most vulnerable, and then we see how to exit in the district, but leave a supportive structure that can support the girls from drawing back into the vulnerabilities. We have realized that as a result of the lockdown for 2 years, which actually made Uganda a star in the lockdown above all the other countries, it left extreme vulnerability to the girl child and to the boy child. Now, the biggest challenge is that we will keep talking about the girl child because there are results that show that she has been exposed, she has had sex because she's pregnant, she's carrying a baby. When we see the boy children who are actually equally suffering, but they're not seen, it's because they're into depression, they perhaps lead into alcohol and substance abuse and drug abuse. They are getting into all sorts of crime because of limited attention. What is the call for here? Of course, we know the allocation that comes in for young people is catalytic, and it is targeting the adolescent girls and young women. It will not, and again I say, it will not consider the boys because I've already had a look at it. Now the question is, as we do prioritization here, can we come up with priorities that could target the ecosystem of the girl child so that the boy child is also supported through the support to the girl? We've realized that we really need to increase, and we have started on it. We are working together with JMS, we are working together with the Joint Medical Stores, National Medical Stores, and Ministry of Health, the condom programming team, so that we increase condom distribution up to community level. For those of us that have had access to where dispensers are, we know that there are cobwebs, meaning there has not been replenishment of condoms within those dispensers. So what does that mean? That the users are really having a stock out and there's a crisis, which will expose them to a risk of HIV. Of course, we had also to scale up the GBV interventions. We are working in 20 districts, but in the initial districts, Chankwazi and Padel, we had to really bring in the issue of GBV interventions, because as a result of the lockdown, I think everyone has become depressed. And as we saw from that, 14 million Ugandans have mental health challenges. And as a result, it settles down to that girl child and boy child in the household. And the repercussions of these GBV interventions really are not the best that we would want, but they also leave lifelong impacts on the people they are in, which include trauma that cannot really easily be eliminated. So what we have learned in our implementation during 1.5 years is that GBV has intensified as a result of COVID beyond what it used to be. The champions would report maybe like 5 cases in a month, but we have seen since the lockdowns, the minimum that you can get from one person is 7. Who has only waited for those that, but follow up in the communities, they are massive. There has been increased vulnerability. I talked about this. People become poorer initially, where households have become wretched. Girls and boys have been exposed to socio-economic challenges. They have been exposed to mental health challenges, and vulnerability has increased. Initially, we would enroll 100 girls in a vocational institutions, that is in NFM1, that is 2018-2020. And out of these 100 girls, you would have 5 babies at most. But now, because of as a result of COVID, for every 100 girls that we enrolled in vocational schools, we had not less than 30 babies. What does that mean?